Okay, welcome to episode 16. And due to popular demand, we are doing this very difficult question, the cardiovascular changes in obesity. And the reason why it's difficult is just the amount of information that's out there. And the really sort of challenge in this question is really to fit all that into 10 minutes. So this presentation will be a little bit different. I'm just going to go through with you the evidence as well as what has been presented in a lot of the core texts prescribed by ANSCA, as well as the references in which they get their information from. And I'm just going to let you know about how I thought about the information and how I eventually came up with a summary, those 4 points that I presented in the Patreon page. Now, as always, with the breakdown of the short answer question, we're going to review the examiner's report. And then after that, we'll do, I'll show you my literature review, present the key concepts, and then he'll have time for questions. And then I'll show you a structure to the answer that I will write down. And we're all going to write an answer to time. So this was the 2016-2018 question, which was describe the cardiovascular changes that occur with morbid obesity. And this is the examiner's report. So this question required a well-organized approach to score highly. Information was sometimes presented effectively in flowchart diagrams, but explanatory detail was often missing in this approach. Acknowledging adipose tissue as an endocrine organ with brief description of the relevant mechanism of action of the principal hormones involved, then segues into discussion of the physiological cardiovascular changes. Quite a lot of, this sentence there's quite a bit to unpack there. The main points expected included changes in blood volume, cardiac output, heart rate, stroke volume, contractility, and the ECG. Effects on blood pressure as distinct from systemic hypertension was expected. Additional marks were awarded for demonstrating understanding of left and right ventricular pathophysiology, hypercoagulopathy, the role of inflammation, endothelial dysfunction, and the reasons for exercise being poorly tolerated. Latitude was given for confusion around the term obesity cardiomyopathy. Explanations of BMI grades attracted no marks, nor did extensive discussion of comorbid conditions. Just with this statement here, I acknowledge that the 2018 actually did require you to give a definition of morbid obesity. So I think just to expand what this sentence is trying to get to is that they don't want you to spend too long, all right, explaining all the different BMI grades. In other words, just define what morbid obesity is in terms of the BMI, and then continue your discussion with the answer. Common mistakes included vague statements, especially with respect to systemic vascular resistance, repetition of information, and incorrect information, especially with respect to eccentric and concentric hypertrophy. Really, really interesting statement here, because there is a lot of confusion about which one occurs. But we'll go through that and I'll show you a little article on that as well, okay? Terms such as wall stress, tension, afterload, and myocardial work were often used loosely. The use of arrows on each new line suggesting a causal relation to the preceding statement was often perplexing. All right. So just quickly, with the idea of wall stress, wall tension, and afterload, these pretty much, I think, mean the same thing, all right? So they're all interrelated in terms of the way you measure afterload is to measure wall stress. And the way you measure wall stress is defined by Laplace's law, where you actually measure tension. So I think that in that respect, when you are talking about these terms, to make sure that you do it under the aim that you're trying to get across the idea of the changes in afterload. Okay, so I think that's the key point from this statement here. Now, this is a summary of the examiner's report. So I think that to get a pass, they wanted you to acknowledge that adipose tissue is an endocrine organ. And then after that, have a brief description of the hormones involved in the following cardiovascular changes. So blood volume, cardiac output, contractility, ECG, blood pressure. And then a good pass or additional marks you'd get for discussing left and right ventricular pathophysiology, hypocoagulopathy, role of inflammation, endothelial dysfunction, and poor tolerance of exercise. There is a lot to unpack here. And you know, I guess the challenge is, how do you explain everything here, right, in 10 minutes? And I think this is one of the ones where there's going to be a bit of breadth rather than depth in this. So then I think for the key points here, there'll be a bit of depth, but certainly for these ones here, I think we can do the idea of just listing a couple of these key concepts. And I'll show you how. Now, for the literature, so you can find all the information I've presented in these texts here. So I've used chapter 76, Physiology of Obesity in Power and CAM. And look, that's probably the easiest one to read if you have sort of limited time, all right? Chapter 58, Anesthesia for Bariatric Surgery from Miller's Anesthesia. Again, it probably gives you a little bit more information, but then after that, it increases in the complexity. And if you want, you know, look, I don't recommend you should read all these articles because of time limitations for the March exam. But, you know, if you were sitting in August, I guess you could go through these articles here, because these are the key articles where chapter 76 and chapter 58 come from, okay? Now, what are the goals for today? So with regards to this question here, describe the cardiovascular changes that occur with morbid obesity. The goals are to remember these 4 mechanisms. And the first one is that there is an increase in blood volume and a decrease in systemic vascular resistance. Number 2 is that there's activation of your renin, angiotensin, aldosterone, and sympathetic nervous system. Number 3, there is OSA and obesity hypoventilation syndrome. And number 4 is insulin resistance and its associated disease, the metabolic syndrome. And I'll sort of expand on that as well. Now, I've got a pie at the end here. And that is really an expansion of this idea of the insulin resistance and its associated disease, the metabolic syndrome, because that's when we're going to introduce the other sort of key concepts, okay, which is atherogenic dyslipidemia. P will stand for prothrombotic state. I will stand for an inflammatory state. And E will stand for endothelial dysfunction. And this is all related to the idea of insulin resistance and metabolic syndrome. And there will be, you know, there's this idea that this is actually a spectrum. So for the milder end, it's, you know, you get the insulin resistance, and in terms of increasing severity, then you start developing the idea of metabolic syndrome, for which all these conditions are, including insulin resistance as well, and including activation of your renin, angiotensin, aldosterone system. Now, just be aware with the idea of defining what morbidly obese is. So the reason why I've got this here is that this may become obsolete in the future. It was coined by two Americans called DeWin and Payne in 1963. And they did it because morbid means, it comes from the Latin word morbus, which means disease. And they were actually applying for insurance companies to actually get this rebated. So the way that they would describe this is that they said that BMI above 40 was considered a disease, which is why they considered, which is why they termed it morbidly obese. But you know, in terms of the lay population, you know, the idea of morbid is, you know, this unpleasant or unhealthy fascination with disease. So that's why WHO has often said that the way to classify it is to do it as classes. So class 3 obesity is a BMI above 40, and class 2 obesity is a BMI above 35. But you might see these definitions down for the idea of morbidly obese, which is a BMI above 40. And you might also see that this is also being used, a BMI above 35 with comorbidities. All right, so these are the two sort of definitions that you'll see floating around for the term morbidly obese. Now, this article has come from the first one that I had, the first journal article that I supplied on the Patreon page. So this is from Albert, and this pretty much summarizes, oh, sorry, the first article was from Levy, sorry. And this pretty much summarizes everything that occurs. But the problem with tabling information like this, whilst it's correct, it lacks logical flow. And this is what I think that a lot of trainees do for their answer. They will just write down concepts, okay? What you want to show the examiner is a flow of concepts, a flow of ideas, you know, with the way that you create your paragraph. So in other words, you know, when you've got increase in blood volume, yes, it does increase in stroke volume, but what increases your blood volume first, okay? And then after that, you know, instead of having numbers here, you could have arrows to indicate that, you know, from increasing blood volume, you get increase in stroke volume, increase in arterial pressure, increasing in left ventricular wall stress, which leads to pulmonary artery hypertension, something along those lines. But, you know, what I want you guys to sort of move away is just tabling information or tabling concepts without any sort of logical flow to the idea. Now, on the other hand, this is from Power and Cam, figure 76.1. The thing with flow diagrams like this, whilst it's correct, unless you've got, you know, this amount of detail in, you know, I think that sometimes that flow diagrams lack the appearance of detail. And what I mean by that is they just need that bit of explanation in terms of why these things are happening. So, you know, we know that with increased fat, increased adipose tissue does require that it increases your blood volume. But why is there a decrease in SVR? So these flow diagrams, whilst correct, they don't really have that much detail to them, which is what the examiner was also sort of pointing to. Okay. Now, the previous diagram, so that has come from that first journal article from Levy. So this is the original article with the original diagram. And you can see that there is quite a lot of steps here. And is it reproducible for the exam? Look, absolutely. If you are able to memorize this and reproduce this for the exam, you know, fantastic. You know, for me, the way that I thought about this was I had to get to 2 points here. I had to get to left ventricular failure, and I had to get to RV failure. So the way that I thought about this systematically was what were the key conditions required to lead to left ventricular failure? And then what were the key conditions that would lead to right ventricular failure? And what I sort of came up with was sort of this color code. So let me just move myself down here. Okay. What I've got is this color code here. So with excess adipose tissue, you get an increase in your circulating blood volume, and there's a decrease in your systemic vascular resistance, which is due to parallel capillary beds in adipose tissue. The second thing that occurs is you get activation of your renin-angiotensin aldosterone system, and that leads to hypertension, which leads to increase in wall stress. And you can work your way down this diagram here and ultimately come down to left ventricular failure. Okay, so the two main points that leads to left ventricular failure is an increase in your circulating blood volume and a reduction in your systemic vascular resistance due to parallel capillary beds. And the second main point is the activation of your renin-angiotensin aldosterone system, which then subsequently, when you combine all that together, leads to left ventricular failure. Now, I'm gonna sort of work down these steps here to sort of show you what happens. Have I got a little, yes, I've got a blank page here. With regards to how increasing in blood volume and a reduction in your systemic vascular resistance leads to left ventricular dilation and subsequently left ventricular failure, it's really useful to think about it in terms of the relationship between your left ventricular end diastolic pressure and left ventricular end diastolic volume. So you might have seen this curve before. This is the left ventricular compliance curve, where we've got left ventricular end diastolic volume, and normal is anywhere between 100 to 200, and your left ventricular end diastolic pressure, where normal is somewhere between 5 to 12. And then after that, we've got 20, 30, 40, and 50. This is in millimeters of mercury, and this is in mils. So we've got the curve that looks something like this, where after about 200, it increases exponentially to represent a reduction in your left ventricular compliance. Now, what happens with the increase in blood volume and a reduction in your systemic vascular resistance or afterload is that it allows more blood from the arterial system to return to the venous system and increases your venous return, which then also increases your left ventricular end diastolic volume and subsequently a left ventricular end diastolic pressure or preload. But the problem is that once your left ventricular end diastolic volume becomes excessive, you can see that there's a marked rise in your end diastolic pressure. And so what happens is that the left ventricle dilates, or eccentric hypertrophy happens, okay? And the function of that is to increase the compliance of your left ventricle, so that for a given volume or for an increased volume, there is the same left ventricular end diastolic pressure. Now, if we look at it in terms of the cardiac function curve, so again, we've got stroke volume here on the y-axis. And if you want to know how to think about this, is that normal ejection fraction is about 50%. So normal stroke volume, if you say that your left ventricular end diastolic volume is between 100 to 200, normal stroke volume should be between 50 to 100, okay, mils. And normally with the cardiac function curve, we have a left ventricular end diastolic pressure here. All right, so again, 5 to 12 is normal, and then 20, 30, 40. And so that 50 to 100 should represent what normal is. And after that, you get a drop off in your stroke volume. And that represents that after there is an excessive amount of stretch, you lose the optimal cross-bridging of actin-myosin, as well as the calcium sensitivity for troponin C. So at the straight line here, okay, this is where you get optimal cross-bridging of actin-myosin, and you also get the increase in calcium sensitivity for troponin C. But after that, that starts reducing. Now, what's interesting is that the goal of the left ventricular dilation is for it to maintain this shape of this curve here. Now, if I was to draw this, right? So instead of left ventricular and diastolic pressure, I have left ventricular and diastolic volume. You would see the curve move down this way. All right. So that for a given volume, you're able to still maintain your stroke volume. And that is the function of eccentric hypertrophy. But the problem is that this is pathological. And so that what happens is that as the left ventricle becomes more and more dilated, it moves the curve further and further down and leads to left ventricular systolic failure. What compounds this is that when you get activation of your renin-angiotensin-aldosterone system, this increases your afterload. And when you increase your afterload, you get a further downshift or rotation of this curve. And ultimately, this not only leads to diastolic failure, but also worsens the systolic failure as well. So we go back to this diagram here. You've got a reduction in your systemic vascular resistance and increasing circulating blood volume, which increases your stroke volume. And note, there is no change in heart rate. Your heart rate stays the same. Right? And this leads to an increase in cardiac output, which leads to left ventricular enlargement. And then after that, you get activation of your renin-angiotensin system. So that causes an increasing afterload or hypertension, which increases your LV wall stress. It leads to left ventricular hypertrophy and causes left ventricular failure by both systolic and diastolic dysfunction. And I've just put a color code in. So red and yellow makes orange. All right, red, yellow to orange. And you can do however way you want, but this is just sort of my idea in terms of the way that I sort of thought about it. So 1, 2, leading to left ventricular failure. Now, the challenge is now, how do we get to right ventricular failure? So with right ventricular failure, with excess adipose tissue, you get the association of obstructive sleep apnea and also obesity hypoventilation syndrome, which leads to hypoxia, acidosis, all these things that increases your pulmonary artery pressure, all right? And you can also add hypercarbia as well in here as well. So this leads to pulmonary arterial hypertension, which that causes an increase in your right ventricle afterload, which leads to right ventricular hypertrophy and enlargement and leads to right ventricular failure. Now, left ventricular failure also contributes to pulmonary arterial hypertension. And that leads to, again, right ventricular hypertrophy and right ventricular failure. So again, I've color coded it again, that this is blue and this is orange. So blue and orange leads to brown. So in other words, right ventricular failure is from a combination of OSA and obesity hypoventilation syndrome, as well as your left ventricular failure. And hopefully with this color coding, you start to see a lot of symmetry with all the diagrams that you'll find around the articles, as well as in Power and Cam as well. So I'll just quickly show you. This is the article from ELPIT. So that, again, they've got a very similar diagram here. And again, I've just color coded it: systemic vascular resistance and an increase in your blood volume. And then after that, you've got hypertension from activation of your renin-angiotensin-aldosterone system. And this leads to left ventricular failure. And then after that, you've got OSA and obesity hypoventilation syndrome with left ventricular failure, causing pulmonary arterial hypertension, increasing your right ventricular afterload, which causes hypertrophy and subsequently right ventricular failure. And this hopefully will, you see the symmetry as well now in Power and Cam. So again, just to go through, an increase in blood volume and a decrease in SVR from parallel capillary beds leads all the way down here. And then after that, you've got systemic hypertension from activation of your renin-angiotensin-aldosterone system, which then leads to left ventricular failure. And then after that, on the right side, you've got OSA and obesity hypoventilation syndrome and left ventricular failure, all leading to pulmonary hypertension, which then leads to right ventricular failure. Okay, and this is correct too. So they've said that hypoxia and hypercarbia causes pulmonary hypertension, and you can also put acidosis as well here as well. Okay. Now, in Power and Cam, they have eccentric left ventricular hypertrophy here. Okay. Whereas if you actually look at the previous sort of flow diagrams from the original articles, they only have left ventricular hypertrophy. So you see, so these are from the original articles from Levy and ELPIT. They only have left ventricular hypertrophy. So why does Power and Cam have eccentric hypertrophy? And that got me thinking, is it eccentric hypertrophy that occurs, or is it concentric hypertrophy that occurs? Because left ventricular enlargement to me is eccentric hypertrophy. So eccentric, whereas an increase in wall stress leads to concentric hypertrophy. So why does Power and Cam choose one over the other? And this was a question that I had, which sort of didn't make sense to me in Power and Cam's flow diagram. So there is a table which explains this in figure 1, and this is in Levy. So we'll go through this together. Left ventricular hypertrophy in severe obesity may be eccentric or concentric. In uncomplicated, normotensive, severe obesity, eccentric left ventricular hypertrophy predominates. In severely obese patients with long-standing systemic hypertension, concentric left ventricular hypertrophy is frequently observed and may occur more commonly than eccentric left ventricular hypertrophy. So going back to this again, if you have normotensive obese patients, so they don't have the activation of their renin-angiotensin-aldosterone system, eccentric will predominate. But once you've got activation of your RAAS, you get hypertension, and then after that you get concentric. All right. So this is the explanation here, which means that this one here from Power and Cam, I don't think this gives the complete picture. And this hopefully makes sense to you that, that systemic hypertension doesn't normally cause eccentric hypertrophy. So this would be an error, okay, from Power and Cam. Not an error, but not quite right. And which is why the original articles just have left ventricular hypertrophy, because you can have both eccentric or concentric. Now, The thing that I will sort of credit Paran Cam for is this idea that coronary artery disease can cause left ventricular failure. And we certainly know that patients who are morbidly obese do have an association with an increase in coronary artery disease, which can contribute to left ventricular failure. So this is something that the other two flow diagrams didn't have. But what they did have, all right, was this. So this was from Albert. They had neurohumoral and metabolic alterations. And that was quite interesting. So I read that. And then I looked at this third article, which was the AHA, the 2021 statement on cardiovascular dysfunction in patients with obesity. And look, again, very complex diagram, because you can see it's just, there's just no flow to it. It just sort of goes all, there's a lot of things that are very interconnected. But one thing that stood out to me from this diagram here is how much insulin resistance plays. Have a look, insulin resistance, insulin resistance, insulin resistance, insulin resistance, insulin resistance, insulin resistance. So that means that this key concept here must play a major role in the development of heart failure. And so my thought was, how do I get the idea of insulin resistance to coronary artery disease? And I think the way to do that is to think about the neurohumoral and metabolic alterations that occur between here and here. And what are these neurohumoral and metabolic alterations, okay, that come from insulin resistance that leads to coronary artery disease that ultimately can lead to left ventricular or right ventricular failure? Well, this is where Miller's comes in. So this table is from Miller's 58.1, and these are the features associated with metabolic syndrome. So there's quite a bit here to unpack. And again, a lot of information here. But one of the things that sort of stood out to me were these ones here. Okay, so atherogenic dyslipidemia, elevated blood pressure, and that's just from your renin, angiotensin, aldosterone system, a pro-inflammatory state, and a pro-thrombotic state, and endothelial dysfunction. And these were all sort of the key concepts that were mentioned in the examiner's report. Okay, so in other words, I want to include these key concepts in my answer here. Now, I don't know whether you could spot the error here. So with the prothrombotic state, you've got plasminogen activator inhibitor. There's an increase in that. And that makes sense because if you are inhibiting plasminogen, which becomes plasmin, which breaks down, you're going to be increasing your prothrombotic state, but a reduction in fibrinogen, right? That doesn't increase your prothrombotic state. So just know that this is an error. Obesity is associated with an increase in fibrinogen, not a decrease. So there's an error here in box 58.1, all right? Now, this is how I thought about this. So insulin resistance and its association with metabolic syndrome, all right, which explains the neurohumoral and metabolic alterations. So from atherogenic dyslipidemia, hypertension, pro-inflammatory state, prothrombotic state, endothelial dysfunction leads to coronary artery disease, left ventricular failure, and right ventricular failure. Now, you can put in blood pressure here, but I've got a little mnemonic which doesn't have that. But you can, you're more than welcome to add that in. But it's called a pie. So essentially, A is atherogenic dyslipidemia. P is your prothrombotic state. I is your inflammatory state. And E is endothelial dysfunction. Now, the other thing that the examiner wanted was a discussion of the hormones involved. And the nice one to think to talk about is the hormones involved in the inflammatory state. The idea is that there's an increase in oxidative stress from an excess in macronutrient intake and an increase in your metabolic rate, which leads to your pro-inflammatory state. And this is a discussion in Miller's anesthesia, in case you want to have the resource there. And the factors above stimulate release of inflammatory proteins from adipose tissues. So these are cytokines, which are TNF-alpha and interleukin-6, and the adipokines, which are leptin, adiponectin, and resistin. And I think that given the examiner wanted to talk about, gave marks for talking about the proteins or the hormones that adipose tissues release, I think these will be a good one to remember. So my little mnemonic for this is, and you can choose again, whatever you want. Children that are tiny by the age of 6 never become adults that are large. So C are cytokines, okay? And the tiny stands for TNF alpha, and I and 6 stands for interleukin 6, and A stands for adipokines, L stands for leptin, and A stands for adiponectin, and R for resistin. Sorry, a little thing here. This was from one of the journal articles, which summarized what the ECG changes are. Now, the ECG abnormalities associated with severe obesity include low QRS voltage, and that should make sense because of the increase in adipose tissue, so the distance between the skin and the heart. You get low QRS voltages and rightward shift in the QRS axis, and the rightward shift occurs due to right ventricular hypertrophy. Now, you can also get ECG evidence of left ventricular hypertrophy, although this occurs with a lower frequency. But I think that is worth adding in. And the final one would be multiple studies have demonstrated that prolongation of the corrected QT interval also occurs. And then what I will have for ECG will be those things. So low QRS voltages, right axis deviation, representing right ventricular hypertrophy, left axis deviation, or you don't need to put left axis deviation because there are multiple, there are different ways to define what left ventricular hypertrophy is on an ECG, okay? And then after that, you can have increase in your QT interval or QT corrected interval. And those would be the four things that I would add as the ECG changes. And this was from an article in Anesthesia and Obesity. So this is Anesthesia and Morbid Obesity. And this is the CEA-CCP article. So a lot of the CEA-CCP articles are really good for the Part 2 exam because they're very clinical based. And it was just good to have this table here, which had a lot of, which has very, a lot of symmetry to what that previous paragraph had. So low voltage complexes, left ventricular hypertrophy, prolonged QT, inferolateral T-wave abnormalities, right axis deviation, and P pulmonale. So that's right atrial to represent right atrial hypertrophy. And that would be how I think about, okay, the cardiovascular changes in morbid obesity. So before I show you my structure, let's see whether we've got any questions. So there's a couple of things in the chat. Okay, Julian, is adiponectin a protective factor of pro-inflammatory? Yeah, really interesting question. Really, really, really interesting question. So, okay, let me have come up to the table here. And I think that, let me have a look at the article from, so I just want to make sure that okay. So this is the article from Miller's, and they talk about the oxidative stress factors that contribute to the inflammatory response, and native immune responses act aberrantly in obese individuals. Natural killer cell cytotoxic activity is depressed with obesity, as are levels of cytokines such as interleukin 12 and 18 and interferon gamma. Other cytokines, primarily interleukin 6 and TNF alpha and adipokines, leptin, adiponectin, adipose-derived resistant are two additional major groups of inflammatory proteins produced and released by adipose and adipose-associated tissue. Now, as you have sort of realized, is that Miller's is not always 100% correct. But you're right. I think, further on, so let's see, proteins classified as adiponectins. Significantly reduced adiponectins are found in patients with type 2 diabetes, and adiponectin reduces both. Yeah, so I'm not, yeah, you can see that here, they appear to have protective effects here. So that is conflicting, isn't it? It also inhibits interleukin 6 production. So yeah, in here, they have it as an inflammatory proteins, but the way that they've described it is that adiponectins are a protective factor. I mean, certainly with what they've described here, isn't it? Significantly reduced adiponectin levels are found in patients with type 2 diabetes. So I guess that the way that you reconcile this is just maybe put a reduction in adiponectins, Julian. So I think that's a really, really good spot. And as I said, Miller's is not always 100% correct with the way that they've described things. It's very rare to find mistakes, but yes, they do occur. And I think this would be one, the way that they've put this here and described it here. Is that okay, Julian, with that answer? Yeah. Thanks for that. I just had conflicting notes, so I just wanted to make sure. No, that's right. So I think that, even though Miller's has it here as grouped in adipokines and to say they're inflammatory proteins, certainly what they've described further on fits in with what you have said in terms of that they are a protective factor. So that would mean that the way that I would change my answer would be that an increase in leptin, a decrease in adiponectins, and an increase in resistin. Okay, so good stuff. Thanks for spotting that. It's going to be challenging, but we'll see how we go in terms of writing, or see how I go in terms of writing an answer. Okay, I'll just show you my structure on how I'm going to write my answer. So I'm going to have a definition of morbid obesity, and I'm also going to have the statement that adipose tissue is an endocrine organ. And then in my sections, I'll have morbid obesity results in obesity-related cardiomyopathy due to a increase in blood volume or reduction in systemic vascular resistance. Secondly, through renin, angiotensin, aldosterone, sympathetic nervous system activation. And then third, OSA, obesity, hyperventilation syndrome. And then 4, insulin resistance and its associated metabolic syndrome, which leads to cardiac disease. And the 5th one, I'll have a little paragraph on ECG abnormalities related to the above. What I also want to do is, I guess, include a statement on exercise, and that's quite easy. You can certainly just say that with heart failure leads to cardiac dysfunction and can also lead to chronotropic incompetence, and that leads to a reduction in exercise tolerance. Something along those lines. All right. Okay. So blue and black, I've got those there. And look, I'm not sponsored by these pens, but highly recommend Jetstream. Yeah, everyone's got Jetstream sponsored by, and look, in fact, I should get sponsored by Jetstream given how much I actually plug them. All right. But these are probably the lowest resistance pens around. And they don't smudge, because I'm left-handed. All right. Ready? Get your exam papers. All right. Let's go. So I'm going to have my definition start. And then I'm going to have changes due to increasing in blood volume and a decrease in SVR. 2, I'm going to have renin, angiotensin, aldosterone, sympathetic nervous system stimulation, three, obstructive sleep apnea and obesity, hypoventilation syndrome. 4, insulin resistance and its associated metabolic syndrome. I think that's quite a bit to write here. What I might do is I might put ECG abnormalities halfway down the page on my 3rd page. So, morbid obesity equals BMI more than equal to 40 or more than 35. Comorbidities. Results in obesity related cardiomyopathy because excess adipose tissue is a highly metabolic, and this excess adipose tissue is highly metabolic and functions as an endocrine organ, leading to increased blood volume. So there's a reduction in SVR due to parallel beds. That leads to an increase in cardiac output from increasing volume due to increase in preload with minimal change in heart rate. Over time, LV dilation occurs as compensation to maintain optimal length dependent activation via the Frank-Starling mechanism. I won't draw a graph yet just in case I don't have time. So you get renin angiotensin. So there's is increasing in your SVR and afterload, along with increasing in blood volume, leads to hypertension. This increases your wall stress or afterload, leads to left ventricular hypertrophy. And you put concentric there, concentric, which leads to LV systolic and diastolic dysfunction, leads to LV failure, increases risk of arrhythmias. And LV dilation, we can put that as eccentric. With obstructive sleep apnea, we're saying that this leads to ischemia, hypercarbia, acidosis, leads to pulmonary hypertension, exacerbated by left ventricular failure, and leads to right ventricular failure, or pulmonary. Okay. Now, this leads to coronary artery disease and cardiac dysfunction from atherogenic lipidemia, pro-thrombotic state, so increase in fibrinogen, increase in transminogen activator, inhibitor, inflammatory response, cytokines, increase in TNF alpha, interleukin 6, adipokines, increase in leptin, increase in resistin, decrease in adiponectin, and then endothelial dysfunction, decrease exercise tolerance due to cardiac dysfunction, hormonal incompetence, and contractility. Last minute, okay. Low voltage complexes due to adipose tissue, right axis deviation, evidence of LV hypertrophy, and prolonged QTC intervals, and also put T wave. Right. 9 minutes 42. Okay.